Hello everyone, thank you for inviting us to present our project L'Amo Presco with a study called Impact of an Early Educational Protocol on the Oral Language of Prematurely Born Children with Phonological Weakness. Multi-center randomized clinical trial directed by Aude Charolais. We learned from the EpiPage 1 study and there was an overrepresentation of minor neurological disorders and academic failures with developmental quotient normal in premature babies. Written and oral language and attention were also affected. Motor theory of speech, role of motor scales in the construction of phonology, from a study by Aude Charolais, reception, programming, execution, transsensory modalities, weakness in oral language in very premature infants, linked to phonological constraint and fine motricities. And then the PHRC National Clinical Research Program on Language and Motor Skills in Very Premature Children, L'Amo Presco 2012. With clinical trials, prospective multi-center randomized double-blind study, Rouen, Grenoble, Le Havre, Saint-Brieuc, Tours, Caen from 2012 to 2015. Hypotheses were that minor sensory motor disorders alter oral language, particularly phonology, and specific short and early stimulation protocol improves language development before the end of the developmental window. The main and secondary objectives were the evaluation of the effect of early, short, protocolized, and specific stimulation on the oral language of former premature babies. To describe changes in language components, dynamic language development, phonology, then lexicon, then morphosyntax. To specify the ability to recover the worked elements based on the heterogeneity of the initial language. Within vulnerabilities, characterize and distinguish children requiring rehabilitation from guidance or monitoring, and to prioritize monitoring. Materials and methods for the PHRC National 2010 to 2015 for 6 centers Grenoble, Caen, Le Havre, Saint-Brieuc, Tours, Rouen, with an evaluation of language characteristics at 3.5 years of age in children born very prematurely before 33 weeks. Phonology and lexicon, syntax and comprehension. Randomized study comparing short and specific early rehabilitation according to a say and do protocol with conventional care. A 2-arm randomization of fragile child at 3.5 years of age, rehabilitation say and do or usual guidance for 6-month rehabilitation weekly, re-evaluation at the end of the rehabilitation. Children born before 33 weeks. At 3 years of age, we did not include cerebral palsies and deafness. We cleared out contraindication, search for free and informed consent, and included. At 3.5 years, children had a below battery, oral language computerized assessment. Some were normal, then we stopped. If they were abnormal, then we stop and send them to a speech therapist to have rehabilitation. The fragile children had the Cosmo, KABC, and Neal batteries and a randomization on the control group or the say and do group. And at 4 years of age, they had a systematic examination with Below Petit again, Cosmo, KABC, and Neal battery. Here were the protocols. At 3 years old, more or less 2 months, there was a scheduled visit. We decided eligibility or ineligibility for the child's inclusion. Once the child was included in the protocol, the speech therapist trained in administers below petit test. The child was part of the fragile group if either 2 items below centile 25th but over centile 3rd, or 1 item below centile 10 but over centile 3rd, or only enunciation at 0, which is centile 3rd. A cognitive assessment with the KABC reference test, and the NEPC by a psychologist trained in monitoring premature infants. An assessment of motor constraint and the NEAL. Based on the scores obtained on the below petit, the children were divided into 3 groups. Normal group, 4 out of 5 items above the 25th percentile on the below petit, and the 5th criterion under the 10th percentile. Fragile group, either 2 items under centile 25th but over centile 3rd, or 1 item under centile 10th but over centile 3rd, or only enunciation at 0, which is centile 3rd. Pathological group, at least 1 criterion under the 3rd percentile. Materials computerized oral language assessment for children consisted of reception lexicon. The examiner showed a rabbit and the child had to say it's a rabbit. Oral comprehension. The boy sleeps and he had to show the right image. Production lexicon. The child had to say rabbit and stool. Words repetition. What is he doing? And he had to say the boy is sleeping. And enunciation. The examiner said the ball here is not broken. Then the child had to complete there the ball is, and then he said broken. At the bottom left you can see the quotation of the assessment. Sensory motor constraints with the Cosmo assessment. First of all, in the top right corner, the child had to pair the 2 same symbols together. In the bottom right, the child had to reproduce the same facial expression. In the middle, he had to draw a line between the 2 extremities without touching the sidelines. And finally, as you can see at the bottom left, he had these unusual forms in a bag and had to pick the same one as it was shown by the examiner without looking in the bag. On the top left, you can see how was this assessment scored. Now the rehabilitation with the say and do with the parents. First, the child and the parent had to say the words together: swimming, caravan, shoe, fishing rod, balloon, and then the parent would tell the child a word, and the child had to say if it was well said or poorly said, like a cake, or the parent could say a cook. The child had to know when it was well said. It was important to have phonological redundancy, imitated in slow motion: a table, a hat, a plate, a fishing rod, and a glossary meaning action. The fork is to eat. Statistics number of subjects. 2 consecutive personal patient series, a mean difference of at least 1.9 units in the below score variation, which ranges from 0 to 16, corresponding to an effect size of 0.404 between ages 42 and 48 months. The sample size was calculated using students' test at a two-sided level or of 0.05 to ensure 90% power for an effect size of 0.404. A total of 260 children would have been required, as if 130 per arm. We screened 552 children, lacked informed consent in 5 children. The pathologic children were 119, normal children 248, and missing data in 3 children. Fragile children were 177, and then there was protocol deviation, non-randomized, 12 children. We randomized 165 children. The protocol completed in 70 children with functional guidance, and the protocol was completed in 73 children without functional guidance. There were no difference between our groups on all the criteria analyzed in V1. Initial population was very homogeneous in both arms. Results: at the primary endpoint, phonology was non-significant at 0.07, and at the secondary endpoint, lexicon production was significant for P 0.001, comprehension was at 0.05, and enunciation at 0.07. Phonology with accountability and intent to treat showed that children who received rehabilitation sessions had a greater mean change difference, increased by 0.57, than children who did not receive rehabilitation. After the 6-month period, there was a slight improvement for the vocabulary and the work memory for the children who had guidance in the NEPSI and KABC scores. Variation in phonological scores, V1, V22, is related to neurological scores. This is the most interesting result of the study on phonology. All the more, the children had weak motor scores at the Cosmo assessment. Discussion. We found that there was an improvement of production lexicon in all rehabilitated children with fragile phonology with parental guidance. The speech education protocol Say and Do improves certain components of oral language more than simple parental guidance, but not directly the praxis. The trend toward improvement in word repetition score under the influence of the rehabilitation protocol. This is especially true given that their scores were low and they presented motor characteristics, laterality, as if non-right-handers, graphic gesture. It should be noted that a larger number than expected of children born prematurely had to be excluded because of a true oral language disorder. The originality of the study is the specified vulnerability of oral language development, which risks revealing a disorder in phonological specialization in writing linked with the quality of motor networks, not praxis. Targeted prevention action. The limits of the study were the number of randomized children was not reached, by the sample size calculation. The number of children lost to follow-up is high. More children with pathological conditions than expected. The intent to treat results and multiple imputabilities. The children lost to follow-up were not significantly different from those analyzed for most baseline characteristics. They differed in two characteristics: lower phonological fragility scores in oral language development and fewer respiratory problems. One possible explanation is that children least affected by these problems tended to drop out of the trial, particularly when they were in the intervention group, given the frequency of sessions and the perceived potential benefits. Conversely, children with respiratory problems were more likely to attend consultations if their parents expected improvement. In conclusion, we can say from the study that the benefit of a brief protocol-based stimulation of the sensory-motor aspects of language are even relevant at 3.5 years of age, in premature infants with multiple fine motor vulnerabilities but without pathological criteria. Improvement in phonology is all the more evident when there are fine motor vulnerabilities. Is there a stability of the effect on written phonology? The LAMO study is promising. Thank you all for your attention. Thank you to the LAMO Presco team. Thank you to the parents and children of the study. Thank you to the staff, including the late Professor Lodenbach. Special thanks to Professor Marie Farmer, and special thanks to Professor O. Charolet, who gave me a chance to present this fabulous study.